Okay, so let's start. Welcome everyone to the ERN-RITA Webinar. We welcome you. Today we have a special webinar on vaccination, which we know is one of the topics that we do on a regular basis when patient keeps asking us about if to vaccinate or not to vaccinate our patient with rheumatic disease. You can ask questions through the chat along the talk of Professor Toplak, and following the talk, we'll have a discussion with your questions, whatever you would like to know. So I'm happy to present Professor Natasha Toplak, who is our speaker today. Natasha did her degree in medicine in the University of Ljubljana, and she did all the way from graduation as medical student to become a full professor of pediatrics in University of Ljubljana. She practiced pediatric rheumatology in Ljubljana, a lot of clinical care, a lot of education of residents and students, and she is awarded many times as best teacher in her university and hospital. She is doing a lot of research. Between all her fields is also the field of vaccination. And Natasha serves as the chair of the Working Party Vaccination of the Pediatric Rheumatology European Society. And in such, she leads quite a lot of studies in this field. Natasha, we know that she's a good speaker. She was invited to many places to speak. She's also a good friend. She stayed in our unit in the last year for 3 months. So thank you, Natasha, for accepting the invitation. And the virtual floor is yours. Thank you.
Hello, everybody. Just a minute, I will share my screen with you. Can you see my screen now?
Yeah, we can see it.
It's okay. Can you see my screen?
Switch to the presentation, please. Yeah.
Can you see it?
Yeah, good.
So we are all set. So, dear friends, dear colleagues, it's a great pleasure to have a talk at RITA Webinar, and I would really like to thank all organizers for giving me this opportunity to discuss with you clinical guidance for vaccination in children with rheumatic diseases. Here you can see the outline of my presentation. After a short introduction, I will present you one of my patients. And then I will concentrate on vaccination with non-live inactivated vaccines in children with pediatric rheumatic diseases. And then the main part of my talk will be vaccination with live attenuated vaccines. And then at the end of presentation, we will come back to my patient and I will explain you how we proceeded in his case with vaccination. And then we will also make a plan for future vaccination for my patient. And at the end, I will just give you some take-home messages. There is no doubt that vaccinations are one of the major achievements in medicine in the last century. The most important measure to prevent infection. However, in the last 20 years or so, there have been several reports of adverse events following vaccination, including autoimmune adverse events. But so far, no study was able to prove the connection between autoimmunity and vaccination. Vaccinations are even more important in children who are treated with immunosuppressive drugs, or in general, in children who are immunocompromised. However, as we recently published, the vaccination rate in patients with pediatric rheumatic diseases is low. If you look at the last row in red, you will see that complete vaccination status in our children was achieved in less than 50% of patients who were treated with biologic therapy. If these children were treated with non-biological DMARDs, the vaccination rate was about 60%. As you can see in the last row, 64.7%. But if they were only treated with non-steroidal anti-rheumatical drugs or received intraarticular corticosteroid injections, the vaccination rate was over 80%. And comparing this to vaccination rate in healthy population, which is over 90, is significantly lower. When we are talking about vaccination, we have to ask ourselves, what is the risk of infection in patients with pediatric rheumatic diseases? Well, this could be due to the underlying disease or due to therapy. And as it was recently shown, the altered immune system in pediatric rheumatic diseases can be responsible for serious infection, regardless of the therapy that the children are taking. So this is the study that was recently published for the Turkish group, which was able to show that the highest rate of infection was in patients with systemic oncogenetic idiopathic arthritis, and the lowest rate of infection was in patients with enthesitis-related arthritis. They were following children by infectious disease clinic for a year, and actually they showed that systemic oncogenetic idiopathic arthritis were the most risk for infection. Some older studies showed that serious bacterial infection in juvenile idiopathic arthritis patients are 2 times more the risk comparing to the healthy population. And then, of course, these children are immunocompromised due to the therapy they are receiving. The largest data that we have so far come from PharmaChild registry, where 15,000 JIA patients were included. They were treated with methotrexate and or biologic. And the report from PharmaChild registry tells us that severe adverse events were reported in almost 7% of patients. And even 13 deaths were reported, which were due to severe infection or malignancy or both. But altogether, the most frequent adverse events were infections. What are the main concerns in vaccination of patients with pediatric rheumatic diseases? Of course, there is always the fear of the risk of precipitating flares of rheumatic illness. And there is uncertainty regarding the induction of adequate immunity, especially on the long term. We still miss this data on the long-term protection after the vaccination. And when it comes to live attenuated vaccines, well, we are all afraid of the risk of disseminated infection after vaccination with live attenuated vaccines. So these are all the problems that we face in pediatric rheumatology. When we are talking about vaccinations, we have to address 2 most important points. The first one is safety. Safety always comes first. But the other thing is efficacy, actually. But efficacy is very difficult to measure. If we talk about efficacy, we would have to do a randomized control study, so half of the patients would be vaccinated and the other half would not be, but this is unethical. And efficacy also tells us on the long term if the vaccination will prevent the disease in a vaccinated person. So the studies that we have now, they're studying immunogenicity because we studied the induction of protective antibodies following vaccination, and we have to keep this in mind talking about vaccinations. So I will present you now one of my patients, and he is now a 16-year-old boy who was born in January 2005, and he was diagnosed with polyarticular JIA at the age of 2. And up till then, he was vaccinated according to the national program. And you see all the vaccines he received, also MMR at the age of 1. And he was having quite difficult course. He needed many times corticosteroid injections. He needed also systemic corticosteroids, mainly at the first years of his disease. And then he was treated with methotrexate. And then in 2009, at the age of 4, he started etanercept, which worked perfectly for him for 8 years. But then we had to switch to adalimumab. And currently, he's treated with adalimumab and methotrexate, and he has inactive disease. So this boy was in domestic protection up to school entrance in the year of 2011 when he was 6. And at that time, he was taking methotrexate and etanercept, and he was having inactive disease. And parents had a lot of questions. Mainly, they were worried about varicella. infection. Why they were worried about varicella infection? Because we were always telling them, you know, be afraid of varicella infection. This can be very dangerous for your child. And he was not in contact with varicella before school, and he didn't go to kindergarten. So actually parents asked us to vaccinate him. But as you know, this is live attenuated vaccine, and at that time the child was treated with methotrexate and etanercept. And then according to our national program, he should receive the second dose of MMR vaccine, which is again live attenuated vaccine. So what to do? And then according to our program, he should receive hepatitis B. And parents wondered if he's still protected against tetanus. And what about influenza and pneumococcal vaccine? But let us now leave this question open till the end of my presentation. So now I'm moving to the next part of my talk, and I will concentrate on vaccination with non-live inactivated vaccines. Well, as you all know, vaccination with non-live inactivated vaccines are recommended regardless of the immunomodulatory therapy that kids are receiving. And if you look at the last recommendation for children with pediatric rheumatic diseases that were published in 2011, all the regulatory vaccinations are recommended, as you see in the table. And then we have additional vaccinations like influenza every season, and other vaccines. It depends on the epidemiological situation in the country. Like in Slovenia and other central mid-European countries, tick-borne encephalitis is quite a problem, so we do recommend also this vaccine. But when it comes to immunogenicity and the therapy the kids are receiving, we have to mention that in a case of high dose of glucocorticosteroid therapy, or in a case that the child was treated with rituximab or even anti-TNF-alpha therapy, serological response should be tested. And we have to address the problem of rituximab, which deletes B cells. So if a patient who was treated with rituximab has a contaminated wound, it is suggested to give him a passive protection, so tetanus IgG antibodies, because if we vaccinate him, he would not be able to produce the response to tetanus vaccination. It is very difficult to tell you about all the studies in half an hour, so I will now concentrate. I will do a wrap-up of all studies for non-live vaccines, but I will mainly concentrate on the studies that were performed on biologic therapy. So up to 2015, 11 studies, including more than 200 children that were treated at the time of vaccination with biologic drugs, were published. But the main biologic therapy that was studied were TNF-alpha blockers. And as you see on the screen, the majority of studies were published for influenza. One study among all these studies patients who were treated with tocilizumab. This was a group of 27 patients with systemic onset juvenile idiopathic arthritis. And then there was one study for hepatitis C, one study for hepatitis B, meningococcal and pneumococcal vaccine. And after 2015, another 7 studies, including 150 children treated with biologics that received non-live vaccines, were published, but 2 among them only studied immunogenicity. And for influenza, 2 studies were published, one in JIA patient and one in inflammatory bowel disease patient, and for hepatitis B, 1 study. And then the Greek group, Maritzi and her colleagues, they published a study on hepatitis A in 2016, in which they also included children with autoinflammatory diseases. 28 children with autoinflammatory diseases were vaccinated with 2 doses of inactivated hepatitis A vaccine, and 7 among them were on anti-IL-1 therapy. And they observed that 3 children, 1 with hyper-IgD syndrome and 2 with familiar Mediterranean fever, had a flare 14 days after vaccination. And then there was a report about side effects after pneumococcal vaccine in cryopyrinopathy patients. And let us see this in more detail. First, there was a brief report on 7 consecutive patients. 6 were treated with canakinumab. at the time of vaccination against pneumococcal infection. They were vaccinated with polysaccharide pneumococcal vaccine or conjugated vaccine, and they were having severe local reaction, and two also had systemic adverse events. And then on the basis of this report, researchers looked into the CAPS registry, and among 68 CAPS patients who were treated with canakinumab, and altogether they received 159 vaccine injection, majority for influenza. There were also 19 patients that received vaccination against pneumococcal infection. And for all vaccines together, the report from the registry was that there was 14% of adverse events, but almost 70% were to pneumococcal vaccine. Half of the 15 cryopyrinopathy patients who were vaccinated with polysaccharide vaccine got fever. And there were no adverse events in 2 patients who were vaccinated with conjugated vaccine. However, this is very limited data with low number of patients, but it was a conclusion that perhaps it's better that these patients would be vaccinated with conjugated vaccine. 5 serious adverse events, all after polysaccharide pneumococcal vaccine, were reported, and these patients, when it comes to local adverse events, were having more prolonged and more severe reaction to pneumococcal vaccine comparing to the reaction to other vaccines. So to do a wrap-up for vaccination with non-live inactivated vaccines from all the published study, it is safe for patients on biologic and other immunomodulatory drugs. However, we need to be cautious in patients with autoinflammatory diseases because probably more often than healthy population, they can have adverse events, but this is probably because of the disease itself, not because of the therapy they are receiving. When it comes to immunogenicity, immunogenicity in the studies was good, but in the studies where also healthy controls were included, the immunogenicity was lower comparing to the healthy controls. But for the future remains to be clarified how is with the long-term protection and how often these patients need booster doses. And of course, in this time of pandemics, we have to also discuss the COVID-19 vaccination in patients with pediatric rheumatic diseases. Well, all the vaccines that we have for now are non-live inactivated vaccines. So as such, they are all recommended for patients with pediatric rheumatic diseases. But you know that only Pfizer vaccine Comirnaty is licensed above the age of 16. Now FDA and Canada also licensed this vaccine above the age of 12. We are waiting for EMA approval anytime now. But in our center, we did vaccinate children with pediatric rheumatic diseases on biologic therapy who were 16 and older. Approximately, we vaccinated about 20 patients, and they had no side effects and no disease relapses for now, but we need to wait for some time. And at the end of my presentation, you will also hear about the data for vaccination in children younger than 16. Limited data, but at least we have some information on this. So now I'm coming to the main part of my talk, which is vaccination with live attenuated vaccines in children on immunomodulatory therapy. Well, if you look at the recommendation, it is not recommended. However, even in the recommendation from 2011, exceptions are allowed in special situations. And if we read directly from the recommendation, you see that vaccination can be considered on a case-to-case basis, weighing the risk of infection versus the hypothetical risk of vaccination. But only booster doses are allowed if the methotrexate dose is low and if the dose of glucocorticosteroids is also low. What is the evidence base that we have for this recommendation? So before 2015, very limited data. Only 3 studies on booster dose while treated with biologics were published. 2 for MMR booster in JIA patients, and there was 1 study, but not in patients with rheumatic diseases, but in inflammatory bowel disease. And this was vaccination against Varicella zoster virus, but only 2 patients were treated with infliximab in this group with the booster dose, and there were no side effects. But after 2015, altogether, 5 studies were published. Altogether in these studies, there were 136 patients treated with biologic at the time of vaccination. And as you can see, the majority of them received booster dose. And now please look at the table, and you see that the most data that we have for now is for MMR booster. You see in the table that more than 100 children received booster MMR while treated with biologic therapy. The majority was treated with anti-TNF-alpha drugs. And then we have some limited data on Varicella zoster virus vaccination. 22 patients were vaccinated against Varicella zoster vaccine while treated with biologic therapy, 10 on anti-TNF-alpha, 6 anti-IL-1, 4 patients on anti-IL-6, and 2 on abatacept. And then there was a report about 4 patients who were treated with anti-IL-1 therapy who received the first dose of yellow vaccine, yellow fever vaccine, and 1 case who received live attenuated polio. There was 1 vaccinal infection reported in one of these studies, but that patient was also on low-dose steroid and on anti-IL-1 therapy. But for all other patients, no reports were that they would get the vaccinal disease. So in the majority of them, this was safe. So why is this issue so important? You know, we have measles outbreaks every few years. And here you can see the data for the United States, where measles were on the upswing in 2014, and then 2018 and 2019. And I don't have to explain to you how dangerous measles can be. And here you can see the data for Europe, where we had a record year for measles in 2017, 2018. So this is the reason that vaccination in these children is really important to protect them against this infection. So all the studies that we have so far investigated safety and immunogenicity of the booster dose. So the first prospective study was published in 2009, but only 10 JIA patients were included that received booster MMR dose, and only 5 patients among them were also treated with anti-TNF-alpha drugs. Vaccination was safe and effective, or better to say immunogenic, and there were no cases of measles or mumps or rubella after vaccination that would be because of the vaccine. And then in 2013, the Dutch study on JIA patients, 68 patients received booster MMR, 15 were on biologic, but the biologic therapy was stopped when these kids were vaccinated. This was a randomized study. 69 children were not vaccinated, and the conclusion from the study was that it was safe and immunogenic. The largest data that we have so far comes from the PRES Vaccination Working Party. This was multicentre retrospective data collection. 10 countries participated, and we collected 234 patients with paediatric rheumatic diseases that were treated with immunomodulatory drugs at the time of vaccination. You see that more than 100 patients were on biologic therapy at the time of vaccination, almost 100 on anti-TNF-alpha, and then 12 on anti-IL-1 therapy and 4 on anti-IL-6 therapy. And the main outcome of this study was that it was safe. There were no severe adverse events, and we observed no disease relapses. However, This is a drawback of this study because this was a retrospective study, so we need to do it prospectively to better follow the disease activity and the adverse events and also the immunogenicity. So the PRES Vaccination Working Party now started with a big project of the prospective study. We will follow carefully these children who will be vaccinated, and they will only be vaccinated if they are scheduled to be vaccinated according to national vaccination program and if they have stable disease. And I can tell you that the toughest part of this study was to get ethical committee approval. So 5 countries so far made it. So Slovenia, Slovakia, Greece, you know, we are a part of European Union, and also Israel and Turkey. And we already started with enrollment of patients, and so far we included 18 patients. Maritzi Despina, she's the PI in the Greece. She included 10 patients together with her young investigator, Teini. So 9 patients were treated with adalimumab, 1 with etanercept, and then for Slovakia, Tomas Dalos and his investigator, Barbora. They included 4 patients. 1 was treated with anakinra, 4 with methotrexate, and in Slovenia, our young researcher Masha Biziak actually included 4 patients. 2 were treated with etanercept and 2 with methotrexate. And for now, it was completely safe. We observed no adverse events and no vaccine-induced infection. And ethical approval was also obtained in Israel and Turkey. So Dr. Uziel and Kasapchopur, they will start to enroll patients very soon, and we are also waiting for other countries to join us. What about varicella? You know that this is highly contagious disease and can have a very complicated course with encephalitis, pneumonia, sepsis. Deaths has been reported in immunocompromised patients. But what are the data that we have for pediatric rheumatological patients? There is a report from the Swiss Rheumatological Registry published in 2016. The researchers find 16 children who had varicella, and 6 had herpes zoster, and 9 among these patients were also treated with biologic therapy. And 3 children who were treated with biologics had a very complicated course of disease. So they had cellulitis, sepsis, cerebellitis. So up to 2015, actually, there were no data about vaccination against varicella zoster with the first dose of the vaccine. And then actually in our center, parents made us somehow to vaccinate these children. They were so afraid of varicella infection that they asked us, why don't we vaccinate these children? And of course, we were very much convinced that it is much better for these children to vaccinate them with attenuated virus than to expose them to the wild type infection. Of course, we asked the ethics committee for permission, and disease had to be stable in the last 3 months. And of course, we checked the immune system. We did the lymphocytic population and the level of immunoglobulins. And then we decided to vaccinate. And the first report was published in 2015. We included 6 children who were treated with etanercept, 2 with tocilizumab, 1 with infliximab. And the main point is that the vaccination was completely safe. So we observed no vaccinal infection, no disease relapses. However, on the long term, the immunogenicity was not so good, especially not in patients with the etanercept. So after several months, the protection antibodies slowly disappeared. And we continued with this vaccination. So up till now, we included 13 children who were vaccinated. Again, vaccination is safe. However, immunogenicity is in question, but in children who loses the protective antibodies, there is still T-cell response. So this remains to be clarified in the future. So after this study, there has been other studies published in 2017, the Dutch study. They included 49 children on biologic therapy, were only 3 among these children, and after vaccination they also tested T-cell response. And the result of this study was that it was safe and the T-cell response was present. And then in 2018, the German study, they included 23 patients. 9 among them were also treated with biologic therapy. However, 8 patients received booster dose, and this study showed that vaccination was safe and good immunogenicity was achieved after the second dose. And you know that the Dutch recommendation, which were recently updated, they recommend herpes zoster vaccination in a case of high-risk patients. So now back to my patient. Parents were really anxious to vaccinate him against varicella. So actually these parents are the ones who started the whole story. So he was not in contact before school and he was not vaccinated, but he was taking etanercept and methotrexate at the time. So we got ethical approval, we tested his immune system, and parents signed the informed consent. So the child was vaccinated with 2 doses in a time span of 6 weeks. And below in the table, you can see the level of protective antibodies following vaccination. So 1 month after the second dose, he achieved good protection. You see 460 units per milliliter, and the protective value is the limit of 106. But 6 months later, this protection was slowly fading away. And then in 2014, we decided to give him a booster. And 3 months after the booster dose, so this was the 3rd dose of vaccine, he produced the protective antibodies, but this was also slowly going down, but it stayed in the low protective values. However, we also tested the T-cell response in this patient, which was present, and more to the point. In all these years, the vaccination was efficacious because this child was in contact with varicella several times and he didn't get it. What about MMR? As I said, the patient was on therapy with etanercept and methotrexate, and this was in 2011 when he started school. There were no data or very limited data on the booster dose, so we decided not to vaccinate because his protection levels were high. And then we tested his protection level in 2015. As you can see in the table, he was protected against measles and mumps. And as I showed you in my presentation, in 2018, Slovenia was surrounded with red countries, which means these were the countries with high number of patients that got measles. So we decided to give him a booster. At that time, he was treated with adalimumab and methotrexate, and he had no side effects. And the disease remained stable. So what is the plan for future vaccination? We definitely do advise influenza every season. I can tell you his story that 1 year they forgot to vaccinate. This was 3 years ago. Then he got influenza infection. He needed to stop the therapy and he had the severe flare. We needed several months to make the disease inactive again. So from that point on, they will for sure never forget influenza shot every season. And of course, we do advise pneumococcal vaccine and hepatitis B vaccine, especially now that he is going slowly to the adult period. And of course, in Slovenia, we do advise to be vaccinated against tick-borne encephalitis. And it remains to be clarified in the future how often he needs varicella booster or diphtheria and tetanus booster. And because this patient was already 16, we vaccinated him against coronavirus infection with 2 doses of Comirnaty. This is Pfizer vaccine. You see the dates when he received the vaccine. And this was completely safe. And for now, his disease remains stable. And on the long term, we will follow protective levels of antibodies. So to conclude, vaccinations are definitely the most effective preventive measure against infection, including for coronavirus and the pandemics that we now face. And in general, for the non-live vaccines, there are no major safety concerns, but we have to keep in mind that patients with autoinflammatory diseases, because the disease itself can have more often adverse events comparing to the healthy population. But the long-term protection remains to be investigated so that we will be able to see with years how many booster doses our patients need. But when it comes to live attenuated vaccines, it still should be said that we don't have enough data to recommend it on the regular basis, but in a case that there is a very high risk of infection, vaccination can be considered on a case-to-case basis. So thank you very much for your attention. I will stop with my presentation and I will be very happy to take questions.
Okay, thank you, Natasha, for a wonderful and comprehensive talk. Anyone who wants to ask question, you can do it through the chat. We got the first question from Nico Wolfert, our friend, who also deals a lot with vaccination. And he asked about the corona vaccine, the COVID vaccine for patients who are younger than 16. So if there's any data for patients who are between 12 and 16. Okay. And we have an answer. We have a few data about it. So Merav from Tel Aviv Medical Center, can you go on and answer this question?
Yes. Hey, can you hear me?
Yes.
Yes.
Okay. So recently we started a prospective study to examine the safety and immunogenicity of the Pfizer COVID vaccine. Israel now allows immunosuppressive kids to receive the COVID vaccine at the ages of 12 to 15, but only with a special permission. So in Tel Aviv Medical Center, I currently have 6 kids under the age of 16, between 12 and 15, who did receive the vaccine. And I'm happy to report that up till now, the safety was excellent in terms of side effects and also disease status. None of them flared and none of them had serious side effects. And the immunogenicity studies, including antibodies and cellular response, are still ongoing, and we're still in the process of increasing the cohort numbers, also with Sefi, obviously, and also with Natasha from the PRES Vaccination Working Group.
So can you tell how anyone can join this registry of the COVID vaccines?
Absolutely. Yes, whoever who would like to join us is very welcome to email me, and we definitely have a protocol also in English and working sheets, and it's very, it's very straightforward to join, and I'm happy to help anyone with the ethical committee, and you're welcome to join us.
Okay, thank you, Merav.
Okay.
Thank you.
Thank you. This is also a study that they're doing together with the Vaccination Working Party of PRES. So I would like to do it all together. We'll have a large data, which will be much more reasonable to know. Thanks, Merav. We have a question to Natasha. How can people join the prospective study? And if they are able to conclude to add also patient with IBD?
Thank you very much for your interest in this question. For rheumatological patients, you just write to me and I will send you all the necessary papers that you need for the ethical committee. This is the toughest part. You really need to explain to your ethical committee that children will be vaccinated according to the national vaccination program. And we didn't really give a thought about patients with inflammatory bowel diseases, but it's a great idea, because what we want to know in the future is also how the therapy that children are receiving are influencing the immunogenicity. And patients with inflammatory bowel disease, at least some of them are treated with the same drugs that we use in pediatric rheumatology. And please contact me after the meeting, send me a mail, and we will try to find a solution for your group of patients together. And I will be happy really that the gastroenterologist would join us in our effort to show that this vaccination is safe.
Okay, thank you, Natasha. Another question. So far, the study for booster vaccine, do you anticipate that in the future we'll do also for the first vaccine in immunocompromised?
Well, this is a little more complicated because so far we have zero data, and this will definitely come to mind if we will have epidemics of measles again. But as you know, in the last year or two, we only faced the coronavirus infection. Actually, in our center, we changed the rheumatological department completely to patients and other infections that trigger, for example, Henoch-Schönlein purpura, rheumatic fever, or other diseases were not present. So the first dose of MMR on immunosuppressive therapy is tricky. But still, if there would be an epidemic, I am convinced that it's much safer to vaccinate them even with the first dose than to expose them to the wild type virus. But in such a case, I think it would be necessary to check the T cells and the B cells before the vaccination, just to make sure that they are immunocompetent, the children are immunocompetent.
Okay, thank you for all the participants. You are welcome to send more questions in the chat. And here is another one. Yes, Merav.
I just wanted to comment that for the COVID vaccine study, we do include IBD patients who have arthritis. I mean, IBD-related arthritis, who are on biologics.
There is a question, Sefi, where Ausra can find my email. Just put my name in the Google and I'm sure it's there. Otherwise, it's on Printo website. I'm sure you will be able to find it. No problem to find my email.
You can go also to the PRES website. Yes, and in the PRES website, there are guidelines for vaccination. You can find all the working party and all the details of the vaccination working party. Natasha, another question. Do you think, does it matter to vaccinate the booster vaccine for patients who are in remission only, or what regarding disease activity? How do
thank you. Yeah, I understand what you mean, Steffi. I prefer to vaccinate them when they have inactive disease. And not just inactive disease from yesterday, but I do prefer to wait for 3 months of inactive disease before vaccinate them. But we can afford this in a case that we don't have some epidemics of varicella or measles. But again, if we have epidemics, or if a child, let me say, has a wound and he is in danger because of the tetanus, the disease activity actually it's a minor problem. If the child really needs vaccination to be protected against infection, then I would not take in the disease activity into consideration.
Okay, thank you. And Natasha, another question, not regarding the live vaccine, but regarding the flu vaccine. So we had a study of our working party group that show relatively not very high vaccination rate. So what's a policy or strategy to influence how to improve the vaccination rate?
Well, I mean, if you look at the results of the study, that the Spoina is actually the PI of this study. I mean, at least in our center, parents said that the most important thing that influences their attitude towards vaccination is the doctor's opinion. I mean, you still can find a substantial number of doctors, also pediatric rheumatologists, they don't support vaccination so much. They are more afraid of vaccination than they are afraid of the disease. I mean, this is quite reasonable in a time when we don't face epidemics. So I think that the main thing, and at least what I'm doing in Slovenia, is to have lectures for doctors and also lectures for nurses. Because nurses, when the patient come into your office, nurse is the first contact. And if a patient would ask a nurse, what do you think about vaccination? And the nurse would just turn around her eyes or not look friendly on it, then you cannot change anything. So first thing what we need to do in pediatric rheumatology is to educate our medical co-workers and of course doctors. And then the other thing is the public media. You know, if you go to internet and put vaccination in the Google, first you will get all the movements that the post-vaccination, and sometimes it's very difficult to find the relevant information. So I think this is the way to go. Public opinion through the public media, and of course to persuade doctors and nurses that vaccinations are important. If we cannot persuade them, how we will persuade parents? This is the problem that we will have to also face in the future.
Are you able to vaccinate in the outpatient clinic in the hospital or only in the community?
We are able to vaccinate at our outpatient office. So if a child comes for a checkup and his disease is inactive, and if he or she is scheduled for the MMR booster, we can just do this at the outpatient office. So usually we do this by ourselves, which is good. I believe that not all centers have this opportunity, but still it's okay if the child is vaccinated by the community doctor and then we follow the child. We just need an information about the time of vaccination. That's it. We need parents to communicate with us and tell us when the child was vaccinated, because some children, not all of them, were vaccinated in our outpatient office, but some of them also received the vaccine at the primary care level.
Okay, thanks. Let's come back to the prospective study. There's another question. Is there any data on uveitis flare and any plan to include other pediatric rheumatic diseases and therapies such as mycophenolate?
For uveitis flare, it's in our study, but this is not about vaccination, but I just remember that one of our patients with uveitis and JIA had a flare of uveitis after coronavirus infection, because I was collecting the data on the patients who were in contact with coronavirus, and then we checked for the flares, and only one patient actually among almost 40 patients that were in contact with coronavirus, only one among them had a flare, and this was for uveitis. So I would say it would be much better to vaccinate them than to expose them to the infection. And any plan to include other pediatric rheumatic diseases and therapies such as MMF, it is in our protocol, I believe, but for the MMR prospective, because in the protocol we were very, very wide. We included also adult centers that we will check for the immunogenicity in adult patients after the MMR booster in childhood, and actually we excluded no therapy. Also MMF is on the list. But you know, this is ongoing process, and here we really need collaboration. I mean, so far we included 18 patients. In a year we might have 100, but this is still not enough to prove that this is really safe and immunogenic. So only together we are strong. So anybody who has interest, please join us in this effort.
Okay, there are no further questions in the chat for the moment. Let's just say we are coming back and forth from a booster live vaccine to the corona vaccine, which hopefully we'll have a webinar on it in the next few months when we'll have much more collective data. Now there was some uncertainty regarding the COVID. The ACR recommended to hold methotrexate in the week of the COVID injection. We don't do it. I think in Europe also they don't do it. What do you think about it?
There is no data on this, so it's hard to comment. I mean, it's the expert opinion. It's like for the recommendation that we have for vaccination in pediatric rheumatology. I mean, the level of evidence is low, so it's difficult to comment. But we have to take into consideration the expert opinion. But you know, this can be different in different countries. I don't think it's necessary, in my opinion, but this is my opinion, which has no background in evidence base. We have another question, Sefi, if you can see it.
Yeah, we have another question. Can you comment on the post-vaccination myocarditis following the messenger RNA vaccine?
Yes. Well, a very good question. And actually, I learned this on PED-Reuma board from American doctors. They reported several patients who had myocarditis after the vaccination, but I was not able to figure out from that report if some patients had multi-inflammatory syndrome before this, so that they would get the vaccine after the disease of multi-inflammatory syndrome. As far as I understood, these were pediatric rheumatology patients who were vaccinated, and post-vaccination they had myocarditis. Well, so far in Europe, and I think also not in Israel, you haven't seen such cases, but the number of vaccinated patients is really low. And then again, I'm not sure, René, if you can enlighten us which vaccine was used in such cases. Was this vector vaccine or mRNA vaccine? I was not able to figure this out either. So I cannot comment any further because the Pfizer vaccine. Okay, you know that actually this is a good point to discuss Pfizer vaccine against vector vaccine. It's somehow in our perception that Pfizer vaccine might be safer for our patients, but there is no data for this. And then again, you see that after Pfizer vaccine, myocarditis has been reported. And if you look to the basic immunology, mRNA vaccines can trigger toll-like receptor, and by this we can trigger inflammasome. So it's a question also about the safety of mRNA vaccines against the vaccines that have adenovirus as a vector. So in this field, we still have many unanswered questions. And at this time, I am not brave enough to say that one vaccine is better than the other. Sefi, do you have some comment about myocarditis post-mRNA vaccine?
It's a lot of them in the media that there are some cases of myocarditis following the mRNA vaccine. I know that the Ministry of Health is collecting the data, and it's also important for the Ministry of Health to decide regarding the safety of vaccine in the younger age. So there are still, I don't think that they come to full conclusion. Anytime there are a lot of cases of vaccinated, it's hard to know if there is a real relation, or because we have also myocarditis anyhow.
Yeah.
But still, this is a concern. I know it's concern, and we are supposed to report on it. And in many pediatric departments, there were cases like this, and we are collecting the cases.
Steffi,
yes.
In my hospital, there were 4 cases, but and I think overall in Israel, the cases were between the ages of 18 and 30 more. I mean, it's less real kids, but anyway, all of the cases in my hospitals were happening after the second vaccine, and it was very close to each other. I mean, it was about 1 or 2 days after the vaccine. But as you said, it's still being collected. And it's for more, I mean, I would say it's for young adults more than kids. I mean, it's not like the PIMS that is most common in the kids or 10-year-olds on average. It's just more young adults, I would say,
yeah.
up to now.
No, this is what the ability of us today to work together internationally and collect the data together. This is what make the changes. So again, like with what we started, to know if the vaccines are safe or not, no one can do it alone, and no country can do it alone. Only international effort. The same for side effects. So I think also that this data is collected for myocarditis following the vaccine.
Yes.
Another question is any rationale to space out the second dose more than 3 weeks?
I would comment that it's always safe to go with the summary of drug characteristic. And if you hold to this, then you're on the safe side. I don't think it's any rational to space out the second dose, at least in my opinion.
Yeah, we give after 3 weeks. I know in Canada or some states, because the lack of vaccines, they prefer to give the first one to more people, and the second dose is given after about 4 months. So, but the company policy is to give after 3 months, after 3 weeks. Yeah.
Yes, it's safe to, if you can stick with the summary of product characteristic.
Yeah. Okay.
Also regarding the immunogenicity of the vaccine, this is important. To keep in mind the time span that is recommended.
Okay, so I think we are about to end. I don't see any new questions. So first of all, I want to thank Natasha for a wonderful and comprehensive talk, and also for leading all the group in vaccination in Europe, and it could be even international. And with all gathering the data, we'll be able to change the guidelines that instead of calling to vaccinate optional to discuss if to vaccinate live vaccine or not, in the future we'll have much more strong evidence and recommendation to do the vaccination. So thank you, Natasha, and thank you, Merav, also for highlighting the COVID experience and the international study of the COVID. And thank Zenek for the technical assistance. And special thanks to all the people who are here and attend the meeting. The next webinar will be next month. There's no date yet, but you are welcome to join the next one. And this webinar is recorded, so you can come back and listen again. And I wish you a nice weekend and enjoy with the family, with your patient, with anyone. So thank you all.
Bye, everybody.
Bye.
Guys, thank you, Sefi.
Bye.
Bye, Mero. Bye, Sefi.
Bye.
Have a good weekend.
Thank you.
Let us hope we will see each other in real life very soon, because this is this is our reality. So I'm really hoping that we see each other very, 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 very soon.
Yeah.
Bye.
Okay.
Okay.
Bye.
Thank you.